So welcome again to our program today, the Transport Symposium, and thank you for joining for our maternal child health session, breakout session. I'm Christina Pardo, just to give a little bit more on myself, and then hopefully as we engage and interact, as we're speaking, folks can show their lived experience and when they're coming from. The goal of this session is for us, again, we're all solution based. So we're going to identify the issue, but not just the issue, what we see on paper or the numbers, but we're actually seeing from whatever spaces that we're coming from, and then work together to develop an action plan. So I'm Christina Parda. I'm an OBGYN. I trained here at SUNY Downstate. I'm born and raised in New York, coming from a Haitian immigrant family. And so I trained here and worked here for a long time because I wanted to serve immigrant populations, but I wanted to understand the best way to do so. And the only way to do that is to really be in the communities that they serve. So I'm really proud to have trained here and worked here. And as part of that, partner with community-based organizations to understand what's going on and develop solutions. And so as was stated all morning, that partnership is really essential for us to be able to move forward, and hopefully we can all share where our observations and experiences from our journey and then help move it forward. So I want to also just make sure I acknowledge my partners for this session and for also the remaining of the day. I have Jafane Toussaint, who's here, who is our student scribe, who is preparing our presentation for later. And I have my colleague, Dr. Amy Fable, who's the Associate Dean for Community Engagement here at the Downstate School of Public Health. And fortunately, we've done a lot of work here in Brooklyn. So we're going to start with going over or discussing understanding what the issue is. We don't like to focus too much on the numbers, but I do like for us to succinctly say what it is at the highest level that we're addressing. So here we're talking about maternal and child health, specifically and especially maternal morbidity and mortality, and child health, the infant health and infant mortality. As we stated, we know that Black women have the highest risk, but there's a lot just within that. For all women that have barriers and reside in certain communities, no matter your race, your ethnic barriers, you have the risk of increased risk of severe maternal mortality and maternal morbidity. I'm just gonna share some facts from a clinician aspect of what that means. So what that means for maternal mortality is that the highest risks, the highest contributors to maternal mortality. Actually, let me pose this to the group here. What is contributing to maternal mortality in New York City and New York State? And when you respond, if you can just share who you are, where you're coming from, whatever you'd like to share, whether where you're from or organization or type of work that you do. So what is contributing to maternal mortality in New York State and New York City? Who wants to?
My name is Tanisha Oliveri. I am a doula with By My Side Doula Support Program, and I would say mental health, postpartum depression, postpartum mental health issues.
Yes, so maternal mental health, which is actually the leading cause. You can just turn that off and we'll pass it around where we're speaking, is the leading cause or contributor, I should say, for maternal mortality and morbidity. That big contributor to that is substance use, and we heard a great presentation this morning from Agape about what that looks like conceptually. But there's a lot of nuance when we talk about health disparities, and especially how different conditions affect different communities. So we said Black women have the highest risk of maternal mortality and morbidity. And although mental health is the biggest contributor overall, but it's not for Black women. for Black women, it's a different condition that is leading to the increased risk. Does anybody know what that is? So close, it's cardiovascular. Actually, for the New York City one says cardiovascular disease is the contributing. The New York State says hemorrhage is it contributing. So that's why it's important to know these nuances about when we look at disparities, that means we're de-aggregating and seeing the difference between the groups. And if you, New York State and New York City does a really great job of releasing reports every year that, so this isn't me, I didn't study it and, produced it. I read, the reports that New York State and New York City produces. So they even describe it on age. So women over 40, I think I read, said had increases from infection as a contributing. So looking, depending on who you are, even your age means you have a different experience that's contributing to that outcome. Okay, so now that we move away from the actual conditions, let's go further as we know what's contributing to the disparities, what is leading to different groups having different risk of maternal mortality or being able to, or unfortunately succumbing from those conditions, I should say. And the reason why this is important because more than 60% of maternal mortality and maternal morbidity cases are considered preventable, meaning that if maybe somebody received care earlier along the line, perhaps if they didn't have certain barriers or the information or the knowledge or what have you, that it could have been prevented. So let's focus on those. So those social determinants of health we talk about. Does anybody want to define for me social determinants of health?
So if you don't have the food insecurity, the nutrition is very difficult for the mom and the child. And I'm Jeanette Lamar from NYU.
Thank you. Can I have a volunteer? Anybody want to join me up front to write some of our notes down on our stickies up front? Okay, great. Thank you. Do you want to introduce yourself?
Good morning. My name is Edwin, and I am from MNH Family Healthcare. Thank you.
Yes, thank you. You can whichever one you'd like. Mhm. And let me read what we have, some of that we have in the chat. Thank you all for that are joining virtually. Lack of communication and understand between patients, so that patient provider, patient healthcare system interaction, health literacy, hypertension. Now that I'm reading it retro, I don't know which answer you're responding to, but we appreciate the engagement. Systemic racism that's contributing to the barriers. And again, that'll be related to the social determinants of health that we're discussing. And thank you, Dr. Begum, that's joining as a OB physician. And Armel Lafleur sharing a story. I believe recently a Black woman from the Midwest went to a hospital in labor and was told to go home and delivered on the road. And so that leads to, so let's put food insecurity that we had there. So what they're describing there is when we talk about racism or discrimination, which can be at the system level and leads to some of these items that we're going to list here. But there's also that interpersonal aspect, the provider with the healthcare system, the patient with the healthcare system. I always say I start with the system first because that interaction, traditionally we talk about it most between patient and the provider, which certainly does and can occur, but it is also the patient and the healthcare system. So when they're coming in, whether it's the front desk person, the nurse, or whomever, that is may display some aspect of discrimination. So that is that interpersonal discrimination and racism. So we can add that onto here. What else are we seeing in the community? Yeah, so access to healthcare. So as I said in my talk earlier, pregnancy is a stress test for everything. It's a stress test for the individual. So whatever you had before that was lingering, maybe you had mild hypertension, maybe you had undiagnosed diabetes, perhaps nothing that rose to the level where you were diagnosed for that condition. Then pregnancy is a beautiful and amazing thing, but it actually is a stress test on the body. So the body is now having to do much more work with the same system to provide for a growing baby. And it actually, the how do we say, our hormones and everything in our system are shifted. And so those things can lead to whatever was quiet before showing, and almost in everything. So high blood pressure, diabetes, asthma, mental health, everything can worsen during this time period. And so having the healthcare before and after that inter-pregnancy time period is really important. What else that we're seeing?
I work at Diaspora Community Services in Brooklyn. I think one of the things I see, because every month I usually throw workshops for women and maternal health, and we do baby showers and stuff like that for the ladies. They do not know how to gain access to a lot of information, which I see. For example, we did a workshop on SIDS, and a lot of ladies like, I thought my baby could sleep like this. I thought my mother taught me my baby to sleep like this. And then we gave out like free bassinets to those ladies. Now, with those 10 ladies that attended, we know that their baby will be sleeping well and they'll learn how to sleep. So I think it's a knowledge, right? They don't know where to get it from, or they're not doing the research themselves. So it's important that even when we give out our breast pumps, ladies like, oh, they come in, they don't even need a breast pump, they just need information. Why these issues happening to me? Why am I not producing much milk? Why am I? They just need information, and they really don't know how to get that information if they're not doing the work themselves. They rather speak to a person and be like, hey, can you help me do this, instead of going on the internet, be like this and that. They're trying to figure it out.
Yes.
So I think that's one thing.
Yes, thank you for sharing that. And did you introduce yourself? You did? Oh, okay. Do you want to introduce yourself?
Good morning, everyone. My name is Rona Taylor, and I'm the executive director of the Central by Southeast Brooklyn CDC, which is a community development corporation focused on health.
Yes, thank you. So yes, this and that information you just shared about knowledge, literacy, and access to information really is very important. And I appreciate the way you kind of shared it in a nuanced way. So it's not simply, somebody doesn't know, or perhaps it's, the lack of trying, but it's difficult to really know what's important for us to know. Now there's so many things online, and then what is valid and not valid. And then when we go for our prenatal care, we won't point fingers to who's like fault, but when you have like 15 minutes for everything, it's a first pregnancy maybe, or you have a lot that's going on, and you get this folder of all of this great and important information, and now how do you parse it? How do you know what is important for you to do next steps, or integrate it into whatever that you're doing? So that, and not just the knowledge specifically, but the access, and and how do we provide it in a way that is helpful for patients is really important. And also everything is very siloed, right? So the work that you're doing is so essential to really, after the visit, say, hey, let's go through this and take more time to help, people and patients navigate that information. It would do one more, because we know that, really, as we know, it's everything, right? Everything is affecting our patients, and in different ways. So it'd be great if we, as we just did, start to share some, but any themes or stories to go along with it based on what we've seen. Or anything that we haven't listed on here. We have okay. Wow. Oh, I think somebody wants to go into another breakout room. I don't know those instructions. So this is neurosurgical ICU. We get a lot of OB/GYN patients who, despite doctors reaching out to them, never go to their prenatal appointment, even knowing to be high risk. Patients not knowing how to advocate for themselves due to fear, health literacy. Let's do those two first. So that, again, plays a little bit with the health. We'll start with the second one, the health literacy. Actually, the system is so complex, right? If a lot of us, if I, have a mom I'm taking care of and how to navigate her needs, it's difficult, and you have to have some insight of knowing how the system works. So I'm going to advocate for her differently because I know how the system works. And now we have these large institutions that do have excellent care they can provide, but you have to know how to get in the system, get to the right person, to know what they need. I'm going to share a real life example. My mother just had a recent incident, and because of that incident, she has a lot of medications, and she doesn't have access to those medications anymore because of this incident. And then so what happens? You want to go and get new prescriptions, and then what happens? The insurance denies it because they said you already refilled this prescription. And so she has her blood pressure, she has everything. So we have to work through loops and all throughout the system to get her the medications that she needs. And so fortunately, I don't really have the time, but I had the capability of creating time, and I had to work through system and find, if I have to have somebody send the prescription on her behalf, without having to fill out forms and all these type of things, then those are steps that sometimes that you take, but not everybody knows how to advocate within systems or dealing with whatever the primary incident is. So working through our systems is very difficult, and to know how to advocate for themselves. I want to address the first one, never go to the prenatal appointment. Anybody want to share what their thoughts are on that? What may be contributing to somebody not going to their prenatal appointment?
Hi, my name is Jafane. I just want to say that a couple stories that I have heard is dealing with lack of funding. Even though we have access to public transportation, I realize that a lot of expectant moms have difficulties. It's a burden to take public transportation with strollers without getting assistance. I don't know how many of you actually took public transportation and you witnessed moms struggling with the strollers, going up and down the train station, and nobody provides them. Now, reverting back to the prior story that I said earlier, with having a twin and with twins and not having that assistance, it's very hard to commute in public transportation. And if you lack funds to get public transportation, of course, you're not going to be able to get private transportation. So most moms revert back to like, oh, what, I'm just going to miss my prenatal care. Maybe it's not, this one's not as important as the next one. So they're left with choosing between one appointment and another, kind of like prioritizing which one is more important.
All right, so those are things that certainly may be barriers for patients to get to appointments. So often, I think historically, we've always said, that, for the patient is not adhering to recommendations or coming to appointments. And most people, especially when it comes to pregnancy, want to do for themselves, want to do for their child. And oftentimes, even when we see kind of an interaction where, a patient is not happy or you feel actively not doing, there usually is a reason behind that. And it's a reason that it's hard for us to understand. There's a reason hard for us to decipher that or break that down for the patient. But there is and sometimes choices that are being made. We are hosting a workshop next week, and I remember our mom emailed and she said, well, I have to pick up, it's the afternoon, and she said, I have to pick up my 3 kids from the bus stop by 2:30 p.m., so I won't be able, so there's a lot of choices that moms are making. Ultrasound unit, when the ultrasound unit doesn't allow other children, and you have other children at home, what are you going to do? You're not able then to go to your ultrasound appointment unless you can find somebody to watch your child. So that's not an active choice of not wanting to. It's just you don't have the capability, and you start to make hard decisions that we're often seeing. Family abuse, forced to have, yes. So domestic abuse in general. I will say that, as I mentioned in the program that I'm currently involved in, we've seen a spike of domestic violence. And obviously, and what that can be, whether it's through control or active violence, and you see that interaction at times. So we only see a little surface, and certainly those contributors. And as life and everything starts to become more stressful, those things go into the household. And so unfortunately, there's often that we're not able to see or capture. Anything else that we want to add? To partner violence. Oh,
Okay, thank you. The other thing I think is a barrier to language.
oh, thank you. Yes.
I feel that a lot of expectant mothers are not able to come to their appointments because they don't have someone to come with them. And when you go to the hospital, they might not have someone that speaks your language. And we have a large immigrant population. And I think the barrier to language is very, very big here.
Yes, if we expand on that, the language, the immigration aspect, where it's a different system that's already difficult to navigate, the fear of being treated differently within the system, the language difference, not just actual language, but even culturally. And I will say, having that's where a lot of my work in Brooklyn has been, not just in working with communities, but working with the hospital systems to help bridge gaps. And part of why that was important for me to do, having worked in a healthcare system that serves an immigrant population, it's hard. Like, it's very hard for a system to provide the care needed to an individual that speaks another language and is from. So I don't take it or see it fully as the fault of the hospital or the institution, because it's hard. And so you need other people to help you to be able to do that and to bridge the gap. And part of the reason why I started to go outside of institutions to do that, because I saw it with my eyes. I saw where somebody who doesn't speak English, who's pregnant, and trying to get information from an X type of individual, and you see the difference in the interaction. It's easy to just kind of, pass it along, and then the patient is left without the information that they need, because it's hard. And so it's important to state that, and also kind of work across to help to fill in those gaps. And I want to say, it's something difficult to say, but we also have to say that discrimination still also exists for immigrant populations, even within. So even if we say the Black and Hispanic populations, there is discrimination that exists based on socioeconomic status and immigrant status, even within our communities, and it is also important to acknowledge that. All right, I think we have a great summary here.
So I just did want to add to what she just said. There's also like a lack of trust from probably having a bad experience, fear of not being heard or seen. So like, why bother? Like, it's not gonna be a good outcome, or just this inherent fear that you're not seen, you're not heard. I've had so many bad experiences before.
Yes, I agree with that, and I do. Oh, she did a great job. I think the trust is very much in kind of rooted in the discrimination and racism, and also the knowledge information. I think strongly those two contribute to that. I think I saw two more.
Okay, my name is Claudia. I'm master's in the SUNY Downstate. Just to piggyback with what she said, I work at Weill Cornell in the gastro department. I notice that sometimes even the interpreters, they don't have the background of medical, so sometimes they're not actually relaying the message the way we're giving it to them because they don't have the wording per se in their language of the medical background. And I think sometimes that could be a miscommunication to both parties.
Yes, that is again an important nuance aspect to the immigration. And I don't want to respond to that because I feel like we're like going into the what's working in the action plan, and we'll follow up on that.
I think piggybacking off of what Zelda said in terms of like lack of trust, it can also be lack of trust from like the patient and then also from the doctor and trusting what the patient needs. And that coincides with like the racism and discrimination, but I guess it puts it more on the doctor as well. I feel
Yes.
like that's important.
Yes, the healthcare system understanding the community they serve. That's where that historically would say cultural engagement or cultural competency, or I forget what's the newer term that we're using. Humility, yeah. So understanding where we are and understanding that we won't understand everything, but we do our best.
I just wanted to, and no, and I agree with everything. I wanted to also put out a language out there referring to the idea that, patients may not feel empowered to prioritize their own health care because of these other social determinants of health that Dr. Pardo and everyone here have been talking about. These are real competing priorities, like putting food on the table. If I don't have childcare, how am I gonna, and I don't have enough, and I'm working maybe a job and going to school, I need time. Time is costly. I may not have money to pay for an Uber to get to where I need to go. And so I just wanna sort of, I think the language of like, they don't have the time. It's like their days are stressful and they have to take care of so many other priorities, and unfortunately that doesn't allow them to prioritize themselves and healthcare. And so I just wanted to sort of look at it from a different perspective in some way.
And I think, Edwin, while you're taking that, because I was going to ask if you can, share what you want to share, then maybe if you can summarize, re-summarize this for everybody so we can move to what's working. Because as we're talking, I start to hear already some of going into the what's working. So let's summarize what we have here, and then we'll move on to the next.
The last thing I would add is judgment, because sometimes it's very hard to go to the doctors. I always say that to the patients, because when you go see your doctors, you are vulnerable because you have to express things that you would not express to anyone. But I always said, you don't lie to your lawyer, you don't lie to your doctor, because you have to tell them exactly what's going on with you in order for them to help you. And sometimes people keep quiet because they don't want to be judged. And even by your physician, you can be judged. And that's why sometimes people feel restrained and they don't want to say anything that much, even if they see something is wrong, because the fear of judgment, like, I don't know that much. Why do I have a voice? And it's always, that's your health, that's your priority.
Thank you. Do you want to summarize
Yes.
for us everything we have here?
Yes, in the conversation the doctors leads about the understanding the issues, what we have gathered from that, it's as a human being, all of us have to deal with one or two from that board. We're talking about the racisms. Each person here can say at a time in their life, they have acknowledged racism toward them or open unintended to someone else. And then for misappointment, we know sometimes life happen, work, we prioritize everything else but our health. We have time to go see your friends, to have a drinks, but we don't have time to make the appointment. And then we have to prioritize our choices. Sometimes I always tell patients, you have time to go shopping, but you don't have time to take your medications. And as immigrants, some of us are here, I know I am. As immigrants, we always have a fear. Sometimes we don't even know why we do have that fear, but we do. And lack of knowledge is a big one. Language barrier is a big one, and lack of trust. When we put all this together, we cannot navigate the system. Why? Because all these interact to each other. You don't trust somebody to open yourself. You don't have the knowledge to know where to go or to understand the loophole in the paper they give you to read. And you don't have access. And you don't know who to ask. And you cannot advocate for yourself. That make it very complex to the system. And also, we cannot forget abuse. Sometimes we think abuse as a big things, but sometimes abuse starts with little things. And if you don't speak up, you don't say what happened, you don't say what you don't like or appreciate from anyone else, the abuse will continue. Because let me give an example. It wasn't an abuse, but it's just like a diss of someone else. I was sitting in a meeting and we had to do something and I did it and they emailed me, they said that I had to read my informations. And when I get to the meeting, I said, okay, I will do it. They said, okay, wonderful. When I sat in the meeting, there was a new person that came that morning. And as soon as the meeting started, he invoked the subject that I had to read what I had written down. And while I started to speak, he just stopped me and continued talking, just dismiss everything. I felt so hurt. And all the people on the panel, it was a joke, they were laughing. And then they were sending emoji like he was super God. And I was really upset. I cried. I explained that to someone, and that person gave me some word of encouragement. I decided probably I should not go to that meeting anymore. But you know what? I said, I'm a warrior. I will go. And I will go to the next meeting, stay, talk, and say what I had, and say everything I needed to say. But I didn't disrespect anybody. At the end of the meeting, because it was a session for 6 weeks, at the last week, and then they said the meeting was ended and asking for information. And I politely acknowledge and then think everyone else. To me, I felt vindicated because if I had left the meeting, didn't say anything at all, I will have that heavy heart all the way. And it would make it me very close to speak to others. But I stick to it and I look at the person in eyes every day. But I spoke up when I did my review and I tell them what had happened. It shouldn't be happened to anyone else. So that's why they say sometimes abuse can come to so many forms, not just at home or somebody look at you at work. It could be with people you don't even know that treat you very bad. At this point, we need to speak up. And lastly, we have food insecurities and the socioeconomic status, which is very hard these days with inflation, tariffs. We know everyone, even you have the possibility to put food on your table, it's still expensive when you go to the groceries. So all these are the issues the doctor just highlight with all of us to understand why maternal health and child health are very important.
Thank you. Thank you for sharing your story and recording everything for us here. We're going to move on to the next side. You can have a seat. We'll see. We'll try to get another person to help us with the next one. Have any volunteers for the next focus, which is what's working? What's working and what's under addressed? Anybody want to assist? Thank you. Choose your color. Okay. All right. So, we've identified a lot. As we know, pregnancy is everything contributes to that. So, what do we think is working? What programs, partnerships, what have you seen and observed? And I will say, or I won't list everything, but before last year, it was an exciting time in maternal health. Why? Because we were naming the issue. It was in the news. It was everywhere. Maternal health disparities. There was funding. There was programs. There was, a lot. In some aspects, I think in some ways too fast a little bit, because it's important for us to, as we're rolling out things, doing it thoughtfully and then assessing those programs. So let's start to share. What have you seen that has happened that's working? Because there certainly has been a lot of work and programs over the past, 5 or so years. Do. Mhm.
NYU and Bellevue collaborate, and we have a maternal health program. And I believe the maternal health program is very important because what you put in your body is very important, and the oral health is very important. It's the window to the overall health. So maternal health is a very important, but oral health, the maternal health is very important also.
So it's specific to oral health,
Yes.
maternal oral health.
Yes.
Why, can you tell us, since you brought it up, why is oral health important?
Oh.
Why, if you go to when you go to the prenatal visit, your first visit, the doctor or the midwife or whomever is asking when your last dental appointment is. Tell us why.
I believe it's very important because it's the window to health. A lot of women, when they're pregnant, they're afraid of going to the doctor, to a dentist. And maternal health, oral health, is very important because it's the window to overall wellness and getting your cleanings. And sometimes you have to get a dental procedure and you might not be able to get it at that time. So I think that's why it's very important.
Yes, all of those things are important, and also reduce the risk of infection, preterm birth. All right, that's a great one. What else is working?
Think that since, I guess, 2021, New York City implemented the citywide doula initiative. And also there are various doula programs across the city. And I think that there's also been an influx of doulas and doula training programs. And these programs and agencies has helped with maternal morbidity and mortality. The numbers have decreased, well, especially in the program that I work with by my side. We've seen a number of births that had less C-sections and more vaginal deliveries. Sure.
When you look at these,
Mm-hmm.
what is the doula support addressing?
All. All right, let's start with first.
Traditional doula.
Traditional doulas, we support health literacy. Mainly, we support with appointments. I'm looking at missed appointments. Sometimes that interaction between health with the healthcare systems, we are able to support birthing people with understanding what doctors are telling them. So they may not know what the doctor is saying, or the doctor might be very vague, and they rely on us to kind of disseminate information and find out more information for them. The other thing is food insecurities, especially with doulas in the New York City programs. We're sort of like community health workers as well. So we relay information on food insecurity, like food, the food banks, where you can go to find food, mental health resources. We provide information on different agencies that can provide them mental health therapy and all this other stuff. Intimate partner violence, we support with that. But mostly and mainly, our birthing people really look towards us for information, especially health literacy, in terms of health literacy and finding out more information about where they can go, what resources they can use to help during their pregnancy and after birth.
Thank you. Thank
You're welcome.
you for that. So at the big, core of that is the access, the advocacy, navigating complex systems, empowerment during delivery, and with the community-based doula model, they help to support many of the other things. However, I always say it's important to say that, as many doula advocates have told me, doulas can't solve everything. So we want them to do all those things and make sure we have like the built systems around to address the others and help the doulas to connect. So what else is working?
No, I just want to add on to the doula. Oh, one thing I've recently learned is that, most people know about birthing doulas and postpartum doulas, but a lot of women experience loss, recent loss. And I recently learned that there are doulas that are specifically focused on like loss.
Yes, yes. So it's definitely growing, becoming more diverse, even the doula work. We said the general awareness. So within the healthcare system, awareness of disparities, maternal morbidity in the Black community or any impoverished communities with quality improvement initiatives and different things to be able to address it. Better tracking of data. So, we were in a great where, states and cities, not just in New York, created maternal mortality review committees and evaluated it and monitored the data. So that was a big, feat that happened over the past, 5 to 10 years. What else is working well?
C-section.
Is that working well, or is that
Yeah.
yes? What is working well about when you say C-section?
No, I'm asking you.
Oh, okay. So let's summarize. So C-section has been a focus around the maternal health disparities because C-sections increase your risk of some of the outcomes. Bleeding, really heavy bleeding, blood clot in the lung, which is one of the leading causes, infections, increased risk for many things. And so they did show, a trend where the C-section rate has been increasing, and there's some disparities within that where we see Black and brown persons have increased rates of C-section. So we just heard one thing. So first, the information around that. So now it's kind of widely known that C-sections are contributing. So a lot of education and quality initiatives to address that. I will say that is one thing I do think is working is these hospital-based quality improvement initiatives, really looking within the hospitals, seeing where there are gaps, calling out the gaps, and developing initiatives around it. So I think it's been really great for engagement amongst staff, awareness, collaboration within the hospital, collaboration with the hospital and others like community-based organizations. And so I think it may not always come to like that end goal because you may not have the numbers to prove an effect of something, but you see the change just in culture, a quality culture. So I do think that is something that has worked very well. And C-sections has always been a big one of focus to reduce postpartum hemorrhage and C-sections. So one thing we do know that has helped with that is with doula support, more empowered and knowledgeable patients are very vocal, I find, overall now more about C-sections and inductions. And I will say on the clinical side, so there is always a clinical indication for an induction in C-section. That's always important for people and patients to know. But I do see and feel like patients are more like empowered or asking questions regarding that. So I do think there is an overall improvement as it relates to culture, and then with the addition of support persons that helps overall. What else is working well? I think somebody mentioned community health workers. So there's also been an increase funding and support and increasing the access to community health workers to, again, similar to doulas, be able to provide that wraparound support. So, for example, I think we heard from diaspora, individuals from diaspora, and the way they can help to connect to services. And same thing with my community health worker example that I meant. So there's just adding to the social structure to assist with patients, and I think that is helpful.
Based on your experience and what you're seeing now, do you think there's more collaborations between doctors, well, birthing people, like their OBs, and then their like PCP doctors via Epic or MyChart? Do you think there's more of a collaboration around their whole health and all those things?
Yeah, I think overall I've seen a trend towards that. Using now, you can communicate with the healthcare team using the electronic medical record. There's a lot more information and knowledge around birth plan, for example. So I think that going along, somebody said earlier about the awareness has affected everything within the healthcare system, the patients, community members. So then when I give talks, with healthcare institutions, earlier on in this process, I would always say that the patients know. So they know they're reading these stories, they're getting all this information, so they know, it's going. So we have to be prepared to be able to respond or support their needs because they know much. They're more in tuned into kind of what's being reported because it's all over social media and the news and everything. What else? Anything on here that we have on here that we feel that is what's working, and then we can go to what's under addressed. Yes.
I don't know that this is necessarily working, but there is a database at the state level that helps connect doulas to women who are, or birthing people who are on Medicaid, I believe, so that they can get doula support services. But I know that it exists, but I don't know if it's working well.
Yeah, the doula access. We'll put this one on there so we can continue what's under address. So, everything is always a building block. So we talked about doula support and access and the information. And then for me, I see that as maybe a stepping stone. So they did create this online platform to match, and from my experience, I don't think everybody fully knows about that, but the fact that it was formed is like a big first step towards the next step to how do we get it really to like people's hands and fully understand it, so that it existing is an important first step, and then kind of going from there. So it's so interesting you said that because we did work this past summer on creating a patient-facing sheet that has a QR code to that site so people know. So those are the things then those of us in community and maybe that's going towards action plan can start to develop some solutions based on what exists, and then obviously moving forward what doesn't exist at all.
Thank you. Good morning, everyone. My name is Kima. I'm here under my United for Brownsville hat, but I also am a doula outside of my official role. And so listening to you just now speak made me think of and remember, while I'm happy that Medicaid is covering doula services for individuals, so that's working, but leading to what is under, what could still be further developed, the process to become a Medicaid doula, you have to enroll in each individual plan. It is a process. So I became a doula underneath the CDI umbrella, which is amazing. I'm happy. I got into doula work for this, but it is excruciating to sign up for the individual plans.
Yes, I will say thank you for making that point. As I was saying in the earlier talk, the operations of things is such a barrier and really can be so burdensome. So welcome to healthcare and institutions, and why there are so many offices, because it's so burdensome just as you described, and then now as an individual, you have to be able to navigate that. So that is something under addressed.
Hi, everyone. I'm Sheba Ibote. I'm actually a primary care doctor at Health and Hospitals, Kings County, and also faculty for the residency program, the primary care internal medicine program. So I wanted to address two things because we were talking a little bit about like the primary care role. And although I agree with what's been shared, that I think EPIC and EMR has allowed much more communication between OBs and primary care, and the information sharing has shown that more patients are coming to me, especially as they're planning their reproductive journeys. I do feel like there needs a little bit more building around the connection of resources. I do feel like being equipped to know how to get my patient a doula or access to that, knowing kind of what resources are there for them is still something where I'm growing in. And I think that's a shared experience for a few primary care doctors. And so trying to figure out how to bridge that within all of the systemic, issues of time, limited time when we're taking care of our patients. And then something that has been said is this idea of trust in language and communication. And I'm grouping them all together. I think a lot of times how we communicate as physicians specifically with our patients, there is a language and a health literacy component, but I think education around how to maximize within our minimum time, that communication aspect, I feel like that can help with trust overall. I think a lot of times, even when I'm using what I believe to be the plainest language and simplifying what I want to share, and I think that goes for a lot of healthcare providers and everyone who are experts in healthcare, it can be challenging for patients. I have friends and family who are, master's degree holders, also physicians, and they still feel like they're not understanding. And so that takes time and a lot of resources. And having that training, I think, is super important and might be an area of growth as well.
Thank you for that. Is that training for providers?
Yeah,
For healthcare
it's for healthcare
systems, how
systems.
to
At the systems
navigate?
level.
Yes.
I think we kind of stop our communication training at residency level, and I think that can go beyond that.
Yes, it was such an important point, and I think medical schools is doing a better job now of teaching future healthcare professionals how to interact, how to navigate, in addition to obviously the biomedical and traditional information. And I will say, to go along those lines, when a lot of these great funding and programming and everything occurred, there, when I mentioned that sometimes it was too fast because you had all these things coming and they said, you have to do this, you have to do that, you have to do this, you have to add into that, and taking like the time to make sure that the team on the ground, meaning everybody, the front, the nursing, the providers, have like the tools, the time, and the capability to do all those things that they say now we have to do, I think, was a big, gap and added, stress to the system.
I think cultural competency training, that's where it explains also the interaction from patient's point of view and physician point of view. And I think it's a very great tool for doctors to seek and learn from that.
I'm going to add on to that. I'm going to push back like a little bit
Yes.
on that. Is the cultural competency is important, and every institution you sign up to work on your orientation day, you have a checkbox that you participated in a cultural competency training. So that cultural competency and cultural humility has to be reworked in a way that's like actionable, and you really supported and monitored where appropriate. Not that we're policing, providers, but we have a mechanism to see where support is needed, if there's a gap there, and then we have the ability to really like institute it. So sometimes some of these things, on the first day of the training, it's like check boxes. It's completed, but it's not always kind of like integrated and embodied and actionable. But going along this cultural, what about some of the things we said that didn't have great things? Let's talk about like the immigration and language barriers. What do we think is under addressed there?
time, like systemic structures of time. You're thinking about, even if I have a patient that I'm taking care of and I'm using an interpreter, you can imagine they have to interpret everything I say. So that automatically doubles the time, but there's no increased amount of time. So I imagine that's throughout the healthcare system and everyone who takes care of patients.
Yeah, and I'll add onto that. Something somebody mentioned earlier is also about the quality of the interpretation. And, I want to add that there. So maybe we get to action plan. That's something that can be, what are things that can be done? Anything else regarding language, immigration? One thing I don't think that anybody stated that there was a good plan for was food insecurity. Is there anything that people feel they see have worked well, or how and in what way is this like under addressed?
So say, for example, I know that there are a couple of programs where they're doing like food to table pre-made meals for pregnant people. And I think Canva may actually have, in one of their 160 programs, might have something like that. It's like a nutrition, it's a nutrition program, but I think it's like it's not being marketed enough, or it's only limited to those clients, but to be able to scale those types of things.
So just not enough, I guess, right, for how to address food insecurity.
I can also add Andrea from God's Love We Deliver. So we are a medically tailored meal provider, and we have a program specifically tailored for pregnant people experiencing gestational diabetes, and we're also doing some pilots with NYU, a different hospital system. We're doing pilot programs about with the meals and the nutritional counseling and education. Another thing that I think it's working, at least on our end at God's Love, is the 1115 Medicaid state waiver. So you guys know this is a pilot program, but we are providing these meals and also getting reimbursed for them. And we are getting connected with people that we have never worked before, new clients, new families. So also participating in these pilot programs that are here for us as CBOs and organizations is a really great point, really, to get like something good out of the system. So yeah.
Thank you for that. So what do you think within the food insecurity realm is, like, how would you describe it as what do you think is under addressed within that, or I guess the intersection with maternal and child health?
I could say like having access and knowing that for example, the pilot programs and the resources for us as CBOs getting reimbursed for the programs is one of those that's under addressed. And also like including us as a provider on for example, in hospital discharge plans, and having that resource added there in the provider, and providers knowing about the resources that we are providing. I think that's something that we can definitely work on better, just to make people more aware that we exist.
Yeah, so somehow, integrating within systems, the sustainability aspect of the work. I think, yeah, we had something
Yes.
there.
I am proud to say in our medical practice, we have a brand new program under the umbrella Green Energy. It addresses food insecurities a little bit different, because we see food insecurities match with preventions and knowledge, because when we say food insecurity, it's just like you don't have food, but people do have food, but they don't know how to utilize the food, how to eat, and to prevent certain diseases. Those are about food insecurities as well. So in our program, we teach them the prevention, and we demonstrate them how to utilize the food for better health.
Yes, thank you. So that's the nutrition. So increasing the knowledge and awareness of nutrition. And also to add on to that, nutrition is not always a choice, right? So in our communities, if we have do we have access to the healthy foods that we need? Is it affordable for to meet our needs? And we do have a comment here. I think oh, somebody that wants to be connected to you. This is Alexia, clinical nurse manager. Could I be connected with the person from God's Love We Deliver? Also, the person at the front mentioned another food to table service. So if we just share the information, somehow we'll connect. That's Alexia Edwards with our friend from God's Love We Deliver. You're welcome.
So, not necessarily on food insecurity, but the health systems like the Downstate, the Kings County, they have access to these resources. Like they know who to call, their social workers in place. But what about the little urban clinics like the PCP that is like a one-man show with 2 other medical assistants? They have heavy immigrant patients and no real tools to provide to them. Like, okay, I can't show up for my follow-up appointment even though my A1C was 11.2 because either I don't have transport, I don't have childcare, I feel like these little clinics are sometimes forgotten in terms of like social determinants of health, and then they end up in the ED, and it spirals from there just because of a lack of awareness of resources or availability of resources in
Or
these tiny
the
clinics.
capacity for them. That is such a great thing that you mentioned. So I appreciate your saying that. So that integrate the coordination and helping to build at least the capacity of coordination amongst and the information and the tools and awareness amongst the smaller, where probably a good proportion of community members are seeking their care because that's down the street. That's where they've been going for a long time. And then when there's an issue, then they may be probably admitted to kind of within the healthcare system. So that's really a great opportunity there.
I'd like to piggyback on what she just said also. Um, there are a lot of places that you can go to get assistance with the food, but it's the knowledge. It's knowing where those places are. You have churches, you have food pantries, but it's primarily not in the neighborhood that the individual might live. And they might have to go outside of their neighborhood, which is very difficult for them, especially if they have to pay bus fare, car fare, or something like that. So it's important to have the services within the hub, because when you have it in the hub, it makes it easier for people to access it.
Yes, thank you. So a lot of integration, coordination pieces, community side and healthcare side. Another thing that we haven't mentioned anything for is around intimate partner violence, domestic abuse. Where do we think there are opportunities, or how is that underaddressed?
Um, Another thing, with domestic violence abuse, individuals believe that it's physical. It's not only physical, it's emotional. And I believe emotional is more than the physical, because the physical, you could heal from it, the pain, but the emotional, it stays, you ruminate. And I think that's one thing that people go through that is not recognized because it doesn't leave a mark.
Thank you. Okay, so I want to make sure that we are able to move forward with specific gaps or where we say things may be the highest priority. Um, let's expand a little bit on those. I mean, I think we've discussed it, but maybe we can concretely state it. Is why or what are the barriers that we think are keeping us from addressing some of these, or what we stated here as being under addressed? Like I know I heard before about like the operations, so that would be around maybe like staff or capacity. to do, the paperwork or manage through difficult systems. So, organizational staffing constraints / burnout. What are some other barriers we think are kind of keeping us from addressing what we think should happen with the items we list here? Yes, so that's like the capacity, organizational capacity, siloed, everything's here. We just said it like siloed, right? We talked about the smaller healthcare providers, not access to information or organized. And obviously I think we talked about, to go along with siloed system, the integration. So how do we integrate some of the solutions that we know already exist within healthcare systems or even community networks that may exist? Anything else? Funding, but money is always a problem.
It is somewhat spelled out here, but I think ongoing professional development for providers.
Yes. So and the what do we think? What is the barrier to that? Probably funding, right? The time and funding. When you work in a healthcare system, unfortunately, the healthcare system is balancing, the revenue to keep the system going, and those items that need to occur. And unfortunately, sometimes taking away time from clinical care equals reducing what is coming in throughout in the door. All right, if we wanted to list 3 items here that, let me make sure I have my thing up here. If we want to list 3 items that we have identified as under-addressed, and succinctly name them, what do we want to prioritize? All the different support program that now has potential access from things like the Medicaid waiver or funding, but how do we help the system and the organizations to be able to utilize them without burning out, and pulling from other work that is being done? I'd like to suggest one that I think is top of our list, and we did not list anything that we felt was working well, and I think that food insecurity. What do we want to list as a third one?
I think it might be the health literacy piece. As much as we can support and empower patients to learn about what's happening.
How can we put that? Where would we put that in a larger kind of bucket? The communication. Okay, so we'll put the communication. And maybe I think that probably ties into the smaller health centers and the FQHCs and being able to work more collaboratively around resources that's available, because those are kind of the routes that people and patients get their information. Any other suggestions that we want to add to consider, or we're good with that list? Oh, sorry. Yeah, communication and education. So we have a second and third for that. Okay. Well, thank you. Do you want to summarize for us everything we have there? Here. I think also we should just add immigration. We are doing this from a Brooklyn, kind of based perspective, and we know that we are here and we have a large immigrant population. So I think we would be remiss if we didn't add that as well. All right.
So, in terms of what we identified as what's working, are initiatives with maternal health, around oral health, also doula support, better awareness of Black maternal morbidity and mortality. So there's been a better tracking of the data that has resulted in lower C-sections, which is also connected with doula support, but also that providers are making more informed and nuanced decisions about when C-sections are needed. The use of community health workers, and better communication between birthing people and their primary care providers via their electronic records like MyChart and Epic, and potentially the doula database, which also led us into what is being underaddressed, which is the process to become a Medicaid doula, because they need to sign up with every individual program. The resources exist, but we need to be building a better bridge of sharing resources. Also, thinking of ways to maximize the limited time between primary care providers, OBs with their patients. And one suggestion was providing ongoing professional development that goes beyond being a resident. Also, training cultural competency and humility, but being reworked in a way where it's actionable. Let me see. Also related to that is the systemic structure in terms of time in the context of language barriers, because it doubles the time, and also the quality of interpretation. And the last two things have to do with scaling programs that provide meals for pregnant people. We learned that God's Love We Deliver is doing a pilot program, but also it's just the marketing, like getting the word out. And one way to do that is to integrate these types of programs into hospital discharge plans. Additionally, to increase knowledge of nutrition among pregnant people. And lastly, small practices, in particular single primary care providers or smaller clinics, they don't have the awareness of resources or capacity to develop resources for their patients, and being able to help support those smaller practices. And then we decided to prioritize operations, food insecurity, communication, and immigration on a large scale, meaning that it would be threaded throughout all of these things.
Great, thank you so much. Oh,
Hi, my name is Samantha. I'm a financial professional. You'll probably want to know why I'm here. The same way you have identified the impact, food security, and so many other issues impact health and health outcomes. That's the reason why we try to understand our clients for major events such as having a child or changing a job. You mentioned transportation, but I didn't see anything in the summary in terms of what can be done or what is working. In terms of transportation, can you add, if possible, and then you can take it to your action plan, provision of transportation as they do for Access-a-Ride, older individuals? It can be a combination of needs-based and time-based for a person who is pregnant to a certain age of the child. If you can put that there. Thank you.
well, thank you for that. And then you started us very succinctly and detailed onto the action plan, and we have several steps of the action plan started with that. Do you want maybe, oh, well, let me, thank you for doing our what's working, what's under address. Can I have a volunteer for our action plan? Any volunteers? No, I'm on my own. All right, you're gonna do it? Sure. Or I think we had a volunteer here. So let's start with the transportation, because we had a really great example that was already shared. Transportation. So I think you said creating like an Access-a-Ride system for pregnant, postpartum, individuals, that's need-based. Oh. So, let me make sure I get, so who are the stakeholders that's important for that? To create such a system? Who are the stakeholders currently for traditional accessoride?
I am not sure. It is the same people who look after Medicare and Medicaid. It is a long it will be a long action process. It probably has to go through your representatives.
Yeah,
to
so
get
that's like a
approved.
policy.
It's a
Yes.
policy. Yeah.
However, it's a policy if we want it, implemented at the federal and state levels, but we all know how we can influence. Sometimes we have to create a system like that show the impact. So if if we wanted to pilot something like that, then obviously that would require grant funding or some type of way to create a system like that. Perhaps organizations who work in transportation or do some type of mobile transportation, bringing them, that's a little not traditional. So bringing them into the loop of some kind of discussion, because I'm sure organizations exist like that.
To a clinical standpoint, this is the SCN, the social care network. If you do have a patient that have need based for these programs, the physician can just refer them to any social network or the one you are connected with, and the patient will get help from there, and you can follow up with that.
Yes, and I will add, maybe many of our hospital systems have, mini buses that they use to transport employees and certain things. So, that certainly probably are things that exist out there that can be brought together to support pregnant and postpartum.
So we can look at, as Dr. Pardo mentioned, like think out of the box. Why don't we go to the private sector? Uber has a ton of money. I'm sure all these companies, Lyft, Uber, they have perhaps foundations or, money that they would be able to contribute to, I guess, change their image.
Yeah. And they do have certain, but to follow on the model, like that was just shared, instead of individual, perhaps it's kind of like a, accessoride type. And yes, some CBOs have the Omni cards, and so which is important to continue. And I think what the barrier that this is addressing, sometimes that there's a lot of difficulties and challenge with that, especially later in pregnancy when you have other children, you're using the stroller. Or so that is, you want to go ahead? And then I want to make sure time that we move on to one of the other ones.
Thank you. Piggybacking on Uber, there's another organization called Executive Cars. And Executive Cars, they have minibuses, and they can pick up people also, but you just have to get a grant and
Yes.
put it in and then make it
Somebody
work.
has to create the
And-
system
And
for
it
that.
can happen.
Yes, that really was really great. All right, so let's go to food insecurity, because I think we had some specific examples that were also shared for that. For food insecurity, how might we address food insecurity for pregnant postpartum moms? And we'll add into that the nutrition aspect of that. We had an example, so go ahead.
You just said a key word before you gave system. As you were talking earlier, I was like, and you mentioned the QR code. In my mind, you need a system. I don't know what it is. A system where all the players are like in one platform. And when I was thinking of it, I was and access to and wanting to talk, I always try to look at what exists and what is working. And in my mind, I was thinking of the 311 system. in terms of individuals who need access to anything, in terms of a 311 system or built into that system to answer questions that pregnant women may have. So in terms of your food security, access to transportation, comfortable with, building trust to access healthcare, I was thinking system 311.
Let's put that's because we had communication as one of ours. So let's put communication, and then under that is maybe creating some kind of a hub neutral system where pregnant postpartum individuals can rapidly access the information that they need, or to be connected to the resource. So like a 311 for yes, except always say that a lot to people, but 311 is not so easy to navigate, and even I have the app, on my phone. I've called, so I think something that is, and perhaps it probably should be, if we're thinking about community. I mean, I was gonna think citywide, but we're thinking about Brooklyn. So if this would be Brooklyn specific and something that could be expanded, then Bronx can have their own 311, like for pregnant and postpartum. And, and what goes along with that is what we're doing here, organization or something to help bring all those things together in a way that's not burdensome for all the partners. Pull all the information together, organize it, help to create the linkages and the workflows or what have you. And obviously with the input of the community members. So like a Brooklyn-based 311 for, pregnant and postpartum individuals. Yeah, and each borough would have, because the resources, the culture, everything is different for each.
Yes, when it comes to the communication part and education, I think we have to bring it to them. When I was in Syracuse, I worked at Downstate, and just after the mother gave birth, I used to hold classes downstairs, and the mothers would come downstairs to the classes after they gave birth. It was boring upstairs, and they would just come, and then they'll definitely learn about. I used to do maternal health classes downstairs, and also here, my sister just recently gave birth like 2 months ago, and I was in the hospital all day with her. There was like no education there. They didn't give her anything, so not even a video. I think they used to show videos on how to babysit. There was nothing there. So it's just like while they at the hospital and they just giving birth, I know they have questions, and sometimes they're embarrassed to ask questions. But I think those classes and just bringing it to them while they there will be like perfect.
Thank you. And obviously, if we expand on something like that, that's something that can be worked in to like a system or a platform like that. And we should make sure we're right, so that way I'm in compliant with what's here. So the stakeholders who we think would be important for that communication piece. Obviously, we talked, there needs to be some kind of body or hub that can help to like probably what already kind of exists, like this. I was going to say Brooklyn Health Disparity, the Brooklyn Health Promotion Center, that can help to bridge all those things. So there's still some like independence, you're avoiding kind of the layers of bureaucracy, and then able to help and support community organizations, bring all that information together and operationalize it. What other stakeholders would be important in such a venture?
For number 3?
For number 3.
Okay. I actually have
Yes.
something to add there. So someone mentioned the social care networks. What was your name? Okay, so we are familiar with it, with the work that we're doing, and for those of you that don't know, one of the tech platforms that network uses is Unite Us. So I don't know if everyone is aware of Unite Us. So basically, it's a centralized database of all the resources that we've been just talking about. If you need help with language, immigration issues, legal issues, food insecurity, childcare. We developed our own screener specific to the maternal population. If you need baby supplies, if you need a car seat. So that's a centralized data. I mean, there are others, but that's an example of how we could at least coordinate resources. But I definitely like the 311 idea per region, perhaps, because isn't social networks are also by region. So I know that the social care network is Brooklyn and Manhattan, and there's one for Staten Island, and then there's one for Queens. So that could be a potential stakeholder for number 3, and this whole 311 idea, which I like. Yeah, I don't know why we don't think about, providing resources when they're in the having childbirth and postpartum. I definitely like that idea. I don't know how I see that almost as a separate project, but that's definitely an opportunity to provide support. And I'm not sure why systems are not doing that.
Yeah, I will say to this one, if to be like to kind of share my honesty around this and the gap with some of the great things that we said. There's always great things that are happening, and then as they're happening, then sometimes you see like the gaps. So the Social Care Network, Public Health Solutions, United are all wonderful and phenomenal. I still think it's very institution and organization focused. So when we say something like this, where you can call or go in the app, and then it's, I'm having problem with X, we're even still searching for childcare. It's still kind of in our thought process. So something that can help bridge connecting to these social care networks and platforms that exist that can be a little bit more people and person and region specific is what I think about when I think of something like this. And also a lot of times with these programs that it works better when when the patient is in an institution. Then they're doing this assessment and assessing the needs and then sending. And if you don't do that, maybe you missed it, or you didn't have time to stay, or there's something more urgent, and there's always a process with that. This can be something that's a little bit like a faster access, or to get in, to be connected, to bridge to things that already exist. Healthcare system. And something like this would have to be neutral to all of these things. So, the different institutions as a part of it in hospitals. This, Joanne, hi Joanne, a good friend from Brooklyn Public Library. She made an excellent point. What about those ineligible for Medicaid? This is a huge gap. As we know, there's a lot of folks that are in need and have barriers that are not eligible for Medicaid, and then not eligible for many of the resources that we talk about. That's number one. And number two is, we're expecting down the pike that some people are going to lose their eligibility. So the same folks that we're eligible for, have the same challenges, may lose the access, including our immigrant population. So that's a really good point around the organization and communication and creating, organizing what's accessible to folks and thinking about those that are not Medicaid eligible or are not enrolled in Medicaid. All right, so let's, thank you, those who are joining, anybody that wants to join the conversation, you're welcome. All right, so we have maybe, 20 minutes. Do we want to move on? Should we go back to the food insecurity? I think we had go ahead.
Also, I think we need to acknowledge not just the maternal and the postpartum delivering people, but those who have experienced loss. Somebody made mention of it before, and I think we can work it into an action plan for that population.
Thank you. And that is something that can transcend probably everything here, at least the communication and the operations. For the food insecurity, there was a great idea that our action plan that was suggested to integrate that into hospital discharge summaries, anything that helps to streamline things are great. What would be stakeholders for that? Obviously, the hospital, insurance. Insurance is stakeholders for everything. They go across all of these. And those who focus and specialize on food insecurity.
Yeah, I second that. I just wanted to add, like, you can see that the joining factor for all of these things is the stakeholders at the government level, the insurance level. And so kind of taking into like what policies, like action of like writing out to legislators, because something like Medicaid, there is a transportation program for those who are eligible in Medicaid, but that also has faced cuts. We also have people who their expertise, our social workers, for example, that I get to work with, they have access to these resources way better than some providers can. And then we're facing cuts from that as well. Same thing with community health workers. So how funding is distributed, that, my community health workers and my social workers are key for me to provide access, housing access, transportation, and this is even for my people who are planning to have children. So just thinking about who are the legislators in the community who are kind of voting and talking about it. What are the bills that are currently being proposed, and us having a voice in that? Because I think healthcare, there's a lot of barriers for multiple reasons where historically we haven't had a strong voice in those kind of decisions, and trying to expand that. But yeah.
Thank you. I want to add some nuance to the transportation piece. Right now, somebody who has Medicaid is eligible, but it's very restrictive, right? So there's like a list of medical conditions. They said, Dr. Pardo, you said you sent patient use transportation. They give me a list of eligibility, and most of the time they don't meet any of that criteria, and that's specifically for like the Medicaid taxi service. So perhaps this is just adapting to using like a more group or bus made model for those that don't meet that highest risk for that list that oftentimes our pregnant persons do not meet, because it's usually more complex medical conditions. So that's a really good point. Yes, but then they're gonna say we have no money, because it's gonna increase the people that have access to it. What about, okay, our partnership with the Mom and Baby Bus is a start entry point for the ineligible. So she, and that's Joanne Kelly, who leads the community health work for Brooklyn Public Library. And she's referring to actually an initiative with New York Presbyterian where they're doing care via a bus out in the community. And it does provide services for those who are not eligible for Medicaid. Okay, so we talked, anything else for food insecurity? Maybe that's connected to like the discharge. So that way those who are discharged, not just from hospital, but even the clinics, if they screen positive for food insecurity, because now it's going to be a requirement for Medicaid that we have to screen for social determinants of health, that it's automatically like in their discharge instruction. Like, so same thing, they get the discharge instruction from the provider, then they get some information related to their need. And I think for the food, there's a sustainability piece to that also. I think that you were talking about for reimbursement for the food insecurity.
Yeah, and with that, I just think that it's very important to continue the policy and advocacy work of the current pilots that we have. So Yeah, for reimbursement purpose, I think that we currently have those pilots, and then we just need to continue advocating for what we currently have.
Thank you. Okay, so let's move to operations, which I think goes to maybe the coordination and the capacity aspect of community-based organizations. One specific one that was mentioned was the doula enrollment. So I think that's a concrete example for a larger picture. How do we think we can address, the operations gap or capacity gap with community-based organizations?
Hi. I think before you even start anything, you need to do an audit of what you have and what you need, and then you can not duplicate resources and really fill true gaps that exist.
Yeah. So if I can break that down a little bit. So even if we say audit, so if we think it's an important process for individual organizations, stakeholders to audit, how can we assist organizations to be able to do such a process? Because what I have found in working, operate a lot through grants, and the grants will very specifically fund very specific things, and things like auditing or operation support are usually not in that. And then you're kind of scrambling, and people who are program persons are then also trying to figure out the operations and all those kind of things. So how can we support community-based organizations to do those core things that are necessary to operate, whether it's audit or, grants or managing the funding or HR or whatever the case may be?
Sorry, but I'm not sure we're talking about the same thing when I said audit. Maybe we are. When I said audit, I meant purpose, impact, and your outcomes. If it's all aligned and based on the needs we had identified early on, if we are actually truly addressing those.
Yeah, so maybe how can they do self-assessment of their programs?
And therefore, for the action plan,
Yes.
it will be targeted on
To that.
the gaps.
So how do you think we can support that?
Affordable housing is one of them.
I came in a little bit late, but I was really interested in the presentation around the New York Connect, and maybe there's an opportunity through that platform to identify an academic institution or some kind of larger institution who could write a grant to conduct the audit. That way it's like a one-time thing, but they're able to hopefully do it in a comprehensive way to align with what you're saying.
Yeah, so some type of body that, and I guess some of it's maybe created, that can help to support those gaps that exist within operations for them to get to A to B, and also even to assess what they're doing well, what they're not doing not doing well. I want to address, so for the affordable housing, is that related to the operations or something you want to add to the list? That you need to have the
Yes.
access to affordable
Yes.
housing.
And also, one thing we have at our disposition we don't really use is the farmers market. That's part of food insecurities as well.
So the access to the information and resources
Yes.
that's available.
And one thing I want to add, it's the model of screening. Because this is always, from my observation, when we talk about food insecurities or people with needs, we always go to the lowest level. And that's where they need to change the form of assessment. Because you don't know you can see somebody has a good living, sit in a good situation, but this person still has problem for food insecurities. We don't know because most likely when we do the assessment, we do it by checkbox. You have this, you have this, you have this, okay, 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 you're not qualified. And sometimes it's the last resources for that person to come and hear the word no. And they really have the problem because sometimes they said you have to present yourself somehow to get the help. Not having food securities, that doesn't mean I cannot have, wash my hair or do my nails. I need to wash my hair, do my nails, at least to feel better about myself, not having food securities. And I think the reassessment of this program need to be looked at
Yes,
to help people better.
I agree. Those are, the nuance and the complexity of all of these things. And I think you really described it well. And to go back to the audit and the assessment, and to the operations piece, there's a lot of great things that have happened. And I think it is really essential and important that there's a look at it, just like we're doing here, but very focused and specific, what worked well, what should be expanded, what should be adapted, so that way we're efficient in using the funding wisely, and able to support the sustainability. So let's get to the last 10 minutes, and that is immigration or immigrant populations, immigrant health. How do you think we can best support our immigrant populations, our pregnant, postpartum patients that that are considered immigrant population?
Hello, everyone. I'm Chidinma Shuke. I'm an artist, professor, academic, scholar, social entrepreneur. So I work in women development, African and immigrant development, and a few other areas. Okay, so I go to 10 million conferences. I'm an academic. I enjoy research. I read NSF articles for fun. I read NIH articles for fun. That's my jam, right? So when it comes to auditing, assessment, studying, researching, analyzing, there are 10 million articles already on that. It's really accessible. I'm able to help you assess some of those if that's what you really need. The issue is implementation. The issue, all these things we're mentioning, from food security, housing security, postpartum, prenatal care is very important for us to eliminate. And if the woman doesn't know how to eat, if the family doesn't know how to eat or have a home to cook the meal in before pregnancy, chances are there'll be complications with the pregnancy, which will lead to a whole array of issues later on, right? Then we also have the immigrant issue. A lot of these issues we're talking about has to do with, I call them colonial issues, okay? Unfortunately, your race, your income, the language, community, your status in the country tends to correlate with whether you're poor, whether you have enough to eat, whether you're homeless, whether, underhomed, right? It all kind of goes into the same place, right? Initially, someone mentioned about 311, making things more community-based. Yes, it gives me pleasure that I call on the phone, I have someone has a Brooklyn accent per se, I have a Bronx accent. Yes, it feels more homely. But in reality, I find that if I'm in Brooklyn, things tend not to work as well. In most places in Brooklyn, because it's more people that look like us, unfortunately, right? I was at Rockefeller University 2 weeks ago, Columbia University a few times this week. Things there work very quickly. Security was, so peppy and helped me very quickly find my way, Unfortunately, and also when it comes to MT SSRI, we need to hold them accountable that the ones they already have, that they actually get them to place in the same place. People are waiting 4, 5 hours, 6 hours to get places, right? Holding the programs. The issue with the US is that it has so many services, so many government programs, so many similar, right? But in practice, they don't work very well. So you need a lawyer that says them in practice to get them to do what it's supposed to do legally. So the programs already have funding. We need to hold them accountable. Really need more lawyers hold them accountable, or a good thing to write. Once you write one, it's easier to write the other ones, right? Hold them accountable that they have to do what they're supposed to do, okay? People that have Medicaid already have Medicaid right also doesn't work well, even before the funding issues. Didn't work well. So we need to just holding the people accountable that already have the funding, that already have the positions is very, very important. Because all these issues are under the same umbrella. As we over here, your race, your ethnicity, what part of the city you live in, unfortunately, right? Whether you get access to health, pregnant women in vulnerable, you don't have support. A lot of them are single mothers, right? And also, at the end of the day, people need to stay alive today, and your children have to get today. Women, community, let's get together and figure out how we could help each other manage until our government is able to do it for us. Because today, our children need help today. Today, community help today, right? How do we do that? And when it comes to food, a huge part of people don't talk about is that people don't know how to cook. I say this pretty bluntly. Understanding, okay, if I don't have that much money, if I only have $10, if I go to Associated, wherever I go to, if I buy more legumes, my money will probably go further, as opposed to I bought like an egg. Okay. So the legumes will feed you, further, maybe like 5 bags of beans, right? As opposed to maybe buying 2 cartons of eggs. So with the legumes, maybe you have a little seasoning in the house to put in it, a little tomato or something, you could eat, you could live off that and get more nutrition. So people don't quite know how to get the money to spread. So addressing the fact that, yes, farmers market sounds great, but how do I cook that food? So if they don't know how to cook, how do we get the food to the family that need it? Okay, when it comes to a lot of our society, we have high blood pressure, we have diabetes, we have all these crazy issues which have to do with the income and education gap, right? So the government does have, I found about this not too long ago, about prepared food programs. We have certain people able to cook food. Maybe more of us should sign up for that have restaurants, maybe get more accessible to the community. So if you have, let's say, diabetes or have other issues, maybe you could go get food there like a few times a week. Until we forgot to figure out better, yeah.
Yeah, so I think I heard, and thank you for all of that. I heard people kind of centered from the ground up, people and community, but I think what we should put at the top here is like the accountability. I agree fully with that, and I think that goes along with the audit discussion that we've been having, and if we're honest and transparent, that includes amongst, ourselves and what we're doing and who has the funding, and then making sure we're people focused to help with that accountability. One thing I want to say, again, we can't address everything, but I want to use what you said as an example. I know you mentioned like when you go to other institutions like Columbia or wherever, and then things move faster and go in different ways. I've had the fortune to work in state institutions, state hospitals, private hospitals, state hospitals here in Brooklyn, state hospitals out in Eastern Long Island. And the difference is not like the people, it's the money and the resources. It's the money and the resources. Certain institutions have more money to put more people, to put more resources, to put more IT, to make all those systems work better, and to support the staff and make sure there's staff engagement, and to make sure so I want to make sure, I highlight that when we compare like the different hospitals, it's never like the desire or the wish, but it's always like the funding, the resources, and what's able to do. So I want to make sure, because we have we're just about out of time. I wanted to list 2 things that were discussed when we talked about immigrant populations before. I think one was the translation. So being able to have real quality, culturally, community-focused translation. And we talked about the lack of that with the phone translation or video translation. And to be quite honest, I think the solution for that is something that unfortunately is not as easy as like a computer or a phone. It's people, from the community. So when I've worked with immigrant populations when I hire community health workers, I look for people from the community and the community now. So even me, I'm like Haitian American. I shouldn't be the primary person. I want somebody that's like from there and understands kind of the walk of the current the current life. So we talked about the translation, and the second one that I want to offer, just from what I hear from the community health worker that works for me, is the immigration services and the depth of the immigration services. So for example, they do have where maybe there's like legal consultations to do like an application and a guidance. But now when it comes to when you have to go to the court, having the support and assistance for that, the translation, she's calling and looking, where can she get translators for like our moms in the program to accompany them. So really kind of being able to provide practical and actionable immigration support for community members. And that's what I can share from my experience. Anything else anybody wants to add?
Hi, my name is Stacy. I wanted to add into immigration. When you talk about immigration, you also have to talk about cultural competency. Yes, you can provide translation. Yes, you can provide other services, but if you don't understand the person's culture, like you're not really helping them. You can translate something. I'm Haitian. There's multiple ways you can say something, and if the meaning of what you're trying to tell me is not the proper translation, we're not going to have an understanding and able to communicate our needs.
Yes, nor are you going to trust it. Yes, you're going to go home and say, you know, the doctor said X, Y, and Z, and they're crazy. Don't trust anything, yes, that they said. Anything else? Any final, do you want to summarize our action plans or anything anybody wants to add before we close out?
Okay, real quickly to add to what you said, yeah. It's not that you are treated better if you go to Columbia or Rockefeller Center, whatever. It's just that, yes, they paid a little bit better. If you actually have Medicaid, Medicare, like lower income, they treat you differently too. So your race is still a problem for them, even though they're more, more preppy about how they do it. But a lot of discrimination there as well. So we have a race issue, we have an ethnicity issue, we have a poverty issue. Tends to correlate with if you look a certain way, unfortunately. So accountability, I think, like you mentioned earlier, is really the key here.
Yes, thank you so much. Okay, yes. We should, I'm learning a lesson today. Always have a finance person in all your meetings. Because she came with all the practical solutions.
I was a policy analyst.
Yes.
The question, and I'm going off of something you said. I was triggered by something you said. You said structure. Is there any place, space, platform where providers meet and talk and collaborate?
No, probably, it is, I'm a little silent. Well, there is definitely siloed within systems. There are professional societies that exist, but, I always, and we can probably just add that into the operations, the providers piece. But, I think we can do work to do it more authentically for real people. I always find, for example, even with professional societies, when you go to DEI meetings or you go to disparities, you see the same people. It's always the same people. You go to the societies, it's the same people, which is like a small percentage of like the large. So probably in a regional way, like we've discussed, is probably something we can do. How do we connect the communities and the local providers into everything? All right, so how do we summarize and then oh, here. Oh, okay.
All right, so our action plan, the top of everything is accountability. We have transportation, creating a accessorized system, the stakeholders, the grants, funding. We have the social care networks, hospital collaboration, private sectors, the Uber, Lyft, and executive cars, Omni cars that help with the transportation, and Medicaid eligible restrictions for transportations. And there's a organization Mom and Baby Bus. For food insecurity, we have United US. It's a social care network, gives resources, and integrating into hospital discharge, the information for foods, insurance reference, community-based organization, social worker references. They have a lot of information, reimbursement pilots, affordable housing access regarding farmers market and how to cook, like portion size. For communication, we have the 311 Brooklyn, but maybe Brooklyn-based per borough, classes and videos after moms have the babies, stakeholders, Brooklyn health disparities, United US institution as well, hospital systems, and eligible Medicaid insurance and grieving information for the moms. We have operations, the doula enrollment, audits, how to assist organization with grants and funding, self-assessment of programs, affordable housing, body programs to write the needs and assess needs of the community, and the providers coming together during meetings. And we have immigration. You have the race, the income, the status, language barriers. We should have lawyers for agencies to hold accountable with the funding, ethnicity, translation, quality, if it's effective and efficient, the depth of immigration services to have support, assistance, and cultural competencies.
Thank you. I was worried how we do 2 hours, but so that was great. So, and I think in the afternoon, we'll work to refine this into like actionable next steps.